Hi, everyone. It's my pleasure to be here to give the talk about my research. Some of my background, I just joined the Department of Radiation Oncology last year after finishing my medical physics residency still at UM, and I did my PhD here at the Applied Physics program. So that's a little bit about me. I will come to start my talk now. So the title here is Translating Voxels to Practice, Leveraging Machine Learning with Imaging Data in Radiation Oncology. So some background for radiation therapy. On the right side is a linear accelerator. That's the main device that we use to treat cancer patients. This device rotates 360 degrees around the patient. The patient will be immobilized on the couch, and depending on what kind of cancer we want to treat and the disease type, we will use photons, electrons. In some institutions, there's also protons and carbon ions available for the treatment. For UM, we only have photons and electrons. And this machine, as shown in the right, is a varying true beam linear accelerator, or LINAC. So the rationale that how we can use radiation to treat tumor is shown on the left figure. The x-axis is a dose and y-axis is a probability. So there are two curves. One is a tumor control probability, which is the one that's on the left side. And the other curve is normal tissue complication probability. So for radiotherapy, we want to find the optimum dose that we have the good tumor control probability and also limiting the complications as low as possible. So that's kind of a sweet spot that we want to find and give this dose to the specific patient. And this is a radiation therapy process. So the first step is to, based on the physician, they will make a treatment decision. So for cancer treatment, except for radiotherapy, there's also chemotherapy, of course, surgery. So based on a tumor board discussion, if a patient is referred to have radiation therapy, then we will have the second step to have the patient in the CT simulator to get a planning CT ready. And that CT for the third step will be used to contour the tumors, and the physician will prescribe a dose that's desired for the tumor, and dosimetrist will do the treatment planning based on this planning CT. And the next step is primarily our job as a medical physicist. We will review these plans and make sure it's correct and accurate and most optimal, and do the QA. And if there's anything that's suboptimal, we probably will want to replan it. And then after all these are ready, we will do the radiotherapy delivery. So the patient will be like lying on the couch, as I shown in the linear accelerator. And after the treatment, there's always follow-up depending on the type of disease and physician. Sometimes it's 3 months, every 3 months, sometimes it's like 1 year. So that we will know how the tumor control and normal tissue complications are. So this comes to like an overview of my research. So there's this kind of panomics or omics of radiation oncology. So like our routine treatment, there will be different types of data collected, such as tissues, blood biomarkers, and imaging data, of course, as I just shown. So all these different types of data can be used to correlate with our outcome. If we use genomic data, it's called genomics, and there's other omics available. So my research mainly focuses on using imaging data and try to correlate or predict the outcome. So it's kind of under this radiomics subcategory. And then, so we analyze the data and try to see how well these images can be informative to the treatment response. So the goal of these studies are all focusing on how we can use these images combining with other type of clinical biomarkers and leverage on the state-of-the-art machine learning to help improve patient outcome. So, so we want to predict local tumor control and all distant metastasis. And we also want to know what is the probability of normal tissue complication. And of course, one important thing is what will be the overall survival be and using this type of treatment. And so for machine learning, it has been criticized a lot to be a black box. So in my research, I also want to understand the factors that are contributing to the outcome and to understand what's going on within the model. So based on this, we want to seek ways to have better tumor control and less distant metastasis and less side effect, and finally help to improve the patient quality of life. This is an outline of the talk that I want to introduce some of my work previously. So first one is intrahepatic recurrence prediction. It can be called, it's not metastasis, but it's like we treat the primary tumor for liver cancer patient, but the tumor recurred elsewhere, still in the liver. So it's called intrahepatic recurrence. And the second project I will introduce is still for liver cancer. It's called hepatocellular carcinoma, or HCC. So I combine different modality images and clinical biomarkers to predict the overall survival for this patient. And the third project will steer the towards the head and neck cancer or HNSCC patient. So there are a lot of local and distant progression even after our radiotherapy treatment. So we want to understand and predict how likely a patient will develop this recurrence and try to understand which features are contributing to this and to modify our treatment strategy. So I will start with the first project, the intrahepatic recurrence prediction. The motivation of this work is, although we have improved the tumor control probability to be above 90% using the new stereotactic body radiation therapy, a kind of radiation therapy with low toxicities. However, intrahepatic recurrence elsewhere than the primary tumor remains prevalent. It's like higher than 50%, and is the main cause of death for post-treatment patients. So the goal of this work is try to build multimodality deep learning models to predict the location of progression elsewhere intrahepatically. And based on this, we want to provide some quantitative guidance for the treatment planning. So this is a tough project, but I will show an example to see the feasibility. So this is an example of a patient's liver images. Like the first, these are MRIs. The first two on the top are like different contrast, the same image, as we can see that the yellow circles out the primary tumor, and the red circles out where the tumor recurred after 146 days. And the third figure on the top is a dose distribution. We can see that the higher the intensity or the brighter it is, the higher dose we give to the primary tumor. But because at that time, we don't think that the red circle is a lesion, so we didn't treat it. But after like 100, about a little bit more than 100 days, when we do the follow-up, we found that this red circle actually is a recurrence using these MRI images. So the assumption is there are some signals already exist in the image pre-treatment that we can leverage on. Maybe for the treatment planning, we can modify the dose to cover this red suspicious mass early on to reduce the probability of the recurrence. There are about 102 HCC patients enrolled in this study, and all of them have contrast-enhanced CT images as well as T1 weighted MR images, and also the 3D dose distribution. And the endpoint is like to predict the location of new tumor outside of the previous planning tumor volume after SBIRT based on the Kuhnot segment. Kuhnot segment mainly used in liver surgery based on these Voxels. So it will like segment the livers into 8 parts. So we will use this concept here to predict which segment the lesions end up recurred. There are like 59 patients out of the 122 patients that develop this intrahepatic recurrence. And if you look at the segment wise, so there are 85 segments that have recurred tumor out of the about 900 segments. And this is a distribution of like where the tumor recurs. We can see that segments 7 and 8 and maybe 4A are primarily like the higher probability of having recurrence. To predict it, so we propose a framework to first use a deep learning-based registration method to get the segment for each patient, and then using an attention neural network to predict whether or not a segment will have a recurrence. So as we can see here, the patient CT and the patient MR will be registered by this 551, and then the Atlas CT, which, so just some background, so we don't have the 8 segments for all these patients, so it will take a very long time and effort for physician or anybody else to make the contour. So for this particular Atlas CT, we have the segments contour, so we try to use to register this Atlas CT to the patient, each patient CT, and also deform the corresponding 8 segments based on this deformation. And then for each patient, we will have a segment that segment out these livers based on the Kuhnot method. This is like, so we have the liver and tumor contour and dose distribution. And this is the Atlas segment mask for the Kuhnot. And this green means rigid registration, and the purple is deformal registration using deep learning. For the to obtain the Kuhnot segments, we use a method called voxel morph CNN. The basic idea I just explained. So there will be a moving input image, which is here in our study is a moving Atlas CT, and a fixed patient CT, which we have like around, we have 502 patients, and going through this kind of UNet structure network. And then, so there will be a registration field learned by this network, and we can do spatial transformation, and this moving Atlas CT will be registered to this fixed patient CT. So, and then we can calculate the loss between this output and the fixed patient CT, and then train the model. And this is an example of after this Atlas is registered to the fixed patient CT, how these contours of the Atlas can be applied to the patient and get the patient 8 segments. So it's not perfect, but it's good enough for our purpose for the prediction. This is some more of the mathematical part of the loss function. So there are 2 parts. One is a similarity loss to compare the moved image and the fixed image. And the other is a regularization of smoothing loss, so that the similarity is using cross correlation. This kind of metric is very good at if the 2 images have very different intensity, or it's very different modulity, like CT and MR. And smoothing loss is trying to, so U is a deformation field. Each voxel will have 3 direction X, Y, Z. So we want to make the gradient small, that it doesn't have very weird deformation field. This is kind of a little more detail of the voxel morph structure with the 2-channel input and 3-channel output for the deformation field for each voxel. And the first step is to try to get the segment or Kuno segment. And the second, it will be to predict where the tumor will recur in the segment. And we use an attention network as shown here. It still has a UNet backbone structure. One new technique here is called attention gate that is used here to give more attention to important parts in the images. And then afterwards, there's the output channel. One will be used multiplied by the Kuno segments we already get, and then to average the scores from this segment by using binary cross entropy loss to do prediction. And this is affiliate or surrogate task that can help with final prediction on the top. So we have the primary tumor mask. We can also get the segmentation loss so that if the network learns where the tumor is, it might help to get some more information relevant to our final task. This is some of the details about the attention network. So on the right side, the figure shows like for the gating input, and we do convolution with a one by one kernel, and then we combine or concatenate is with like the UNet structure, like upper or more higher resolution image, and then go through this another convolution. And then the alpha here is a coefficient that is also learned by the network that it will help to know which regions is important for our final task. So this is a result for the unsupervised deformable registration. So for all these 102 patients, it just used like about 2 minutes to get all the contours, 8 segments. Comparing with like manual work, it's kind of maybe several days of work. And the average dice coefficients, the dice coefficient is just a metric showing how good the segmentation is. It's about 0.8, so it's as I just mentioned, it's not perfect. But since we are not, our main task is not to do segmentation, so this is good enough for our downstream task for the prediction of recurrence. And this is an example of the registration result. So this is from left to right is a patient CT, Atlas CT, and moved Atlas CT, and the transformation field and the segments, that's like for the 8 Kuno liver segments. And also the bottom, I show some training process of the total loss and reconstruction loss and the smoothing loss for the network. The results for the prediction of recurrence is not perfect for now. So the 4 images, the first one is if we use only CT, and the second one is if we use only MR image, and the third one is if we only use those, and the fourth one is we use the combined all of the 3 image information. So the combined one have slightly better result in terms of predicting which segment we have recurrence, but it's a little bit far from what we can actually use clinically. So I will continue working on this. I think another challenge we have is although some patients, the pre-treatment image does show signals of where the recurrence is, but for some patients, there's really nothing that we can see using bare eyes in the pre-treatment image to guide the prediction. I think that's one of the challenges. Okay, so I will talk a little bit more about HCC. This is a second project that we have also used multimodality data. So it's a deep survival interpretable radiomics model to predict the survival. The data we have still is contra-enhanced CT images, and there are some other variables like there are 37 clinical factors, including age, gender, and like the liver function test. And there are 56 radiomic features. So these radiomics features are some texture features that are calculated from the images for example, like zone size non-uniformity. So that there are some formula that helps us to calculate these free or design features, which represent how heterogeneous like a region is. And there are also some microRNA data, but unfortunately, there's only a subset of patients have this information. And on the left figure shows a like brief structure of the study with 167 patients in this study. And we use a variational autoencoders combined survival network for each of these different information input, and then use this information and then have a final prediction for the overall survival. And to help evaluate or overcome some of the overfitting issue, we use 10 times 5-fold cross-validation. And this is just show the histogram of overall survival time for the patient. As we can see, it's mostly like the median, it will be about 500 days. This is a network structure. So as I just mentioned, there are three type of input. One is extracted imaging features, which is the radiomics. And the second is clinical variables, including some common age, gender, and lab test. And also the contrast enhanced CT images. So these three parts, and then we use a deep survival loss here, and then combine the kind of prediction from these three channels to get our final result. So for the variational autoencoder, which is used for both radiomics and clinical features, there is an encoder and decoder. And we try to reconstruct the input by this kind of structure. So there are also like two loss. One is a reconstruction loss, and the other is a KL divergence. This is kind of the detail, and there's a latent layer that kind of condense all the information that we want, and then reconstruct it back. So there's one thing is this is a time to event analysis, not a classification work. So there are different conventional models for time to event analysis. Cox model is a very standard one that it's a linear and proportional hazard assumption method. The deep serve is kind of recently people proposed that to change the linear combination here for the hazard function to be nonlinear using a network to get the hazard function. So this is the only change. So these are all, this deep serve is also proportional hazard assumption. It's just a nonlinear calculation for the hazard function. And this is a loss function, which for both the Cox and deep serve model is a partial log likelihood, and this is a hazard function. And the final loss is a loss of variational autoencoder and also the survival loss. This is some more details of it. So Cox model has this partial likelihood as a loss function, and deep serve is the same thing as you can see here, but it adds some regularization, the L2, and also the output to make it not explode after the training. And for the image input, it's a little bit different from the clinical and radiomics variables. So I just use a 3D convolutional neural network. I've also tried 3D variational autoencoder. It doesn't help. Maybe there are too many parameters. So I just simply use a small convolutional network to extract features from images. And some final result that we get. So microRNA is very predictive. However, we only have 25 of them, so I didn't include it in the neural network model. But the simple correlation analysis showed that these microRNAs are highly correlated with some of the radiomics features. As you can see, like this is on the left side is a patient CT, a cropped patient CT. On the right side is kind of a random input. So we see like there are definitely some textures from these images of liver that are somehow correlated with genomic information. This is very interesting, but lacks data for more like complex analysis. And so the table shows the survival prediction result. So C index is the values here is kind of how accurate the survival time to event analysis is a common metric. We can see Cox model, it cannot be used for image data. It can only deal with like one-dimensional features. So that's why this is NA for image. The neural network generally outperform the Cox model, and also the combined combining different types of information will also be better than just using single modality. So I will change the topic a little bit more. So the third project I want to show here, it's I want to emphasize on the explainable survival network. And we also use longitudinal quantitative imaging biomarkers from multi-type of images like MRI and PET. The outcome prediction is due for local or distant failure for poor prognosis head and neck cancer patients. Local failure is a clinical challenge, especially for poor prognosis head and neck cancer patient. And if we can find imaging biomarkers to predict this local failure, we may be able to help identify patients for intensified local regional therapy in the form of radiation boosting, targeted systemic therapy, or surgical intervention. So that's kind of the motivation why we want to do the prediction for this local failure. The purpose for this work is just to identify these patients with high risk of local failure using these multi-parametric, multi-modality imaging biomarkers. And one important aspect is to understand how these features interact in these deep learning models. So a lot of our work has very limited patient sample size, and this one also only have 94 patients, but this is from a randomized phase 2 physiological adaptive trial. And this is some of the basic information. T4 and 3 is a stage of the cancer. We can see this mostly high stage or late stage cancer patient. And for this randomized trial, 41 patients is randomized to a standard arm of chemoradiation therapy, which is 70 gray dose in 35 fractions. And about 40 patients was randomized to an experimental arm. So as I just mentioned, there will be a boost volume that we will give a bit more dose. So this boost volume is determined by a union of persistent tumor subvolume with low blood volume and persisting tumor subvolume with low ADC from pre-treatment to 2 weeks during RT. So this low blood volume and the ADC map are all MRI parametric images that we can calculate based on the acquired MRI and to show some functional or physiological information voxel by voxel for the patient. So what this is saying is that pre-treatment, we will take these images, and 2 weeks after the treatment, we will still take the same image and see the difference if the low blood volume region and low ADC region persisted, then we will kind of boost this volume using radiation. There's some patient that's entered an observation arm because of their small boost volume size. And most patients here, so there are 21 local failure for these patients, and the median follow-up is about 20 months, so it's fairly long. And this is the information that we use to do the prediction. So we have PET, CT, and MRI scans pre-treatment and at fraction 10 or after 2 weeks. And the blood volume map, as I just mentioned, is calculated by modified TOFS model on DCE MRI or dynamic contrast enhanced MRI. And the ADC map is a paradiffusion coefficient. It's calculated from diffusion-weighted MR images. And gross tumor volume is like we contoured on the post-treatment T1 weighted images. And all these images are co-registered to this standard image by rigid registration. And this is an example patient. From left to right are the post-contrast T1 weighted image. And the red and green contours are primary GTV, gross tumor volume, and nodal tumor volume. And the second figure is a blood volume. And the third is an ADC map. And the fourth is a PET image. And on the right is a table showing the input features that we get. P16 status is like commonly agreed to be a very predictive for the outcome. P16 positive has a bit favorable result for this disease. And the boost, if we get the boost or not for the patient, and there's like the GTVs and the low LD, like low ADC volume and mean ADC and some other like all imaging features that we extracted from the MRI or PET images. This for the survival part, so because this is also time to local progression, we still use the same methods as the deep serve. I will not explain it. So one thing different here is because we have 2 time points, we use this recurrent neural network and combined with this Cox-based survival network to get the result. So the first part is a recurrent network to have our 2 time points input. And the second part here is a survival prediction. So the output features from the first network will be here. You're going through a fully connected layer and get the result. This is still the partial log likelihood as a loss function. For the feature attribution and interaction in the deep learning models, so this we used a method called integrated gradient. It basically, as you can see here, is after we trained a network, there will be the output if you have a patient input information, and then we can take derivative of this output function with respect to the input. And this integral is just because, so if we just take it at one point, it will not be robust and have a lot of noise. And this integral helps to reduce the noise and get the real signals and to see how much this input feature xi will contribute to the outcome. And this is kind of the how important this feature is for the prediction. And this feature interaction means how 2 features are correlated or interacted, and then to give certain result. So, but mathematically, it's simply to take the second derivative or take another derivative of this integrated gradient and do the integral. So it will show like if one feature changed, how the importance of the other feature will change. This is the results for the local progression prediction. We have benchmark of Cox and DeepServe and also the recurrent network-based survival model. And we also look at different populations, like all the patients are P16 positive and negative subgroups, because we know how important the infection of HPV is to the outcome. As we can see that the proposed method outperformed the benchmarks is a lot, especially for this P16 positive, we can get to about 0.86 of the prediction. For this is still C index. However, we see that for P16 negative patient, even the best model here gives kind of near random result, which make us think that all the features we have extracted are mainly more predictive for P16 positive patients. Another reason may be because in this cohort of patients, majority I guess about 70% are PCC positive. So this is another reason that why this is more useful for PCC positive patient. On the right side is a Kaplan-Meier plot. So based on our prediction, we were able to, so this is using the median value of the predicted score. We were able to significantly stratify low and high risk patients, with a blue one being a high risk patient with very short like local progression time. And this is a result for the feature attribution in the deep learning. So this left side shows different features, and the higher it is, the more important it is to the prediction. And the color here is kind of for each feature, how it's high value or low values. And this is kind of y x-axis is attribution score. So two information we can get. One is how important this is, and the other is the direction. For example, PCC status is kind of the most important feature. And based on these different like values here, and respect to 0, we can see P16 positive has favorable outcome, which means better outcome. This is consistent with kind of a lot of the literature out there. And the second important is a boost. So the direction also shows boost is favorable. So if we give boost to the patient, they will have a low probability of local failure. This is also great news. And some other imaging features are ranked for following. So like this is a PET, how large the PET metabolic region is. So the higher this PET volume is, the higher local failure probability. So this is also like correct based on our intuition. This is the result for feature interaction, similar to the previous figure. And this left side shows which features interact strongly with other features. And yeah, so the x-axis shows the interaction score. Some information we can get here is PCC status. So this is interaction with like, PCT with other features. So has the most interaction with other imaging features. And boost has the largest interaction with P16 here. So, and also the direction shows boost is beneficial for P16 positive patient. With this known, then we will think why maybe it is not reasonable to boost for the P16 negative patients, since it might not be helpful. And mu1, similarly, mu1 2-week is kind of a ADC MRI feature. It's more important for PCC negative patients. And out of these features, quite a few of them are ADC-based features, which shows like MRI probably have some useful information for the prediction of local failure. For this project, we have a predictive model for local failure using all these multimodality, multiparametric, and multi-time points imaging biomarkers. And we learned how to assess feature attribution and interaction, identify the top ranked features, and review some of the strong interactions of the HPV infection status with imaging biomarker. However, of course, this needs to be validated in a larger patient cohort. With that, I think I finished introducing some of my work. I do want to acknowledge some of the findings for this work. I would open to any questions. So I know it's kind of a lot of information. Well.
As a reminder, if you have any questions when you're online, you can put them in the Q&A box, and if anyone in the room has a question, feel free to speak up and ask. There are no questions, but I'll give it another minute or so in case anyone online is typing. If anyone in the room thinks of anything, feel free to speak up. Now I'm looking at you.
Really great talk. Thank you so much. I was curious on many of these cases are often data limited. So I'm curious if you tried any sort of data augmentation strategies and what your prospects are for increased accuracy with more data.
So I didn't hear very clearly. So the last question is, if I have more data, how the accuracy will change, right? How about the first one?
Have you tried data augmentation?
Oh, okay. Yeah. Yeah, so I've tried augmentation, especially for, so not for this third project, because this is mostly this is mostly like feature input, so it's very low dimension. But of course, for the images, I did try different kinds of augmentation, like so commonly used like you crop the image randomly and you do some transformation. So this kind of method I've used. One thing I haven't used is so there's like some generative method like GANs or recently the diffusion model. They probably can simulate some more patients' data, but I don't know how effective this will be. So yeah, I think data augmentation is definitely needed, especially for our small data set. But I've tried, sometimes it doesn't work. And of course, I think with a larger data set, I believe it will help with the accuracy a lot and the generalizability. Another method that I have tried is to do transfer learning. So there are a lot of pre-trained models available online. Some challenges for that is those are mostly natural images. It's very different from the medical images. So that's kind of a little bit hard to transfer. Thank you for the question.
Any other questions? Not seeing any in the room or online, so let's thank our speaker one more time.
Thank you so much. Yeah, it's my pleasure to be here. If you have any questions, reach out to me through email. Thank you.
Thanks everyone for coming.